Okay, good morning, everyone. Thank you for joining us for this year's Year in Review. I'm Dr. Sophie Corvo from Hamilton, Ontario, and I'll be one of your chairs moderating today's session, along with my co-chair, Dr. Jerry Nick from Denver. So today, as you've seen, we'll have 4 speakers, each speaking for 20 minutes, and this will be followed by a 40-minute discussion. Feel free on the app. You can pose your questions throughout the sessions, and then we'll be directing it to the speaker at the end of the session. So again, it's in the app under the question and answer, and you can input your questions directly. I'll give people another minute or so to get seated. We'll also have microphones. If at the end of the session you're interested in posing your question, we can pass the microphone along around the room. Okay, so we're going to get started. So our first speaker today is Dr. Megan McGarry, and she's coming to us from the University of California, San Francisco. She'll be speaking on update on newborn screening.
Good morning, everybody. It's just so good to see everybody back in person, and I'm so excited. Let's see if we can get this close. Is that better? Okay. So good morning, everybody. Come on in. It's so good to see everybody in person, and I'm really excited to present so many great papers on newborn screening. It's been really interesting this year. There's just really been a boom in this research, which is just really exciting to see. So let's see. So overall, first we're going to talk about papers that discuss improving the newborn screening process. Then we're going to talk about outcomes of newborn screening, equity in newborn screening, and then special considerations for newborn screening in the era of CFTR modulators. I posted all the links to all the papers we're presenting on Twitter, so if anybody's interested, rather than having to Google a lot, they're all listed for your pleasure. So first, improving newborn screening process. So this paper was discussing about Colorado's newborn screening process and doing QI iterations, looking at how can we improve and decrease missed cases. So what the Colorado newborn screening protocol is IRT, and then DNA. They had a fixed IRT cutoff of 60, but they also had an ultra-high IRT cutoff referred for sweat tests, no matter what variants were found. And what they had found when they looked back is that the IRT levels of their population actually shifted over time. And I think that's really important for people to think about. If you haven't looked in your own state, your IRT levels may have shifted as well. And so this is part of the problems with a fixed cutoff, is that it went from 97th percentile to only the 99th percentile. And so what they did is they went through and they looked at multiple floating IRT cutoffs, looking at how it would have caught missed cases. And what they determined is that using a 96th percentile cutoff, with also a 50 fixed cutoff as well, really corrected the sensitivity. So once when they went back and they used this new IRT cutoff, it would have caught 7 of their 8 missed cases. So really, the take-home point is floating IRT levels really improve your sensitivity and equity on this, and really should be a consideration for any state that's currently using a fixed IRT level, because IRT levels really change over the population over time, especially in the age of climate change, because they are heat dependent. So something to start thinking about and maybe to go back to your public health department and discuss. So the next paper is looking at a custom next generation sequencing assay for CF newborn screen. So New York newborn screening protocol originally was IRT DNA sequencing, but they had a limited panel that they used. And they expanded it and they evaluated it. And so what they did is that the first tier is now 338 variants, which is just amazing. And then the second tier, what they do is they unblind all the variants, and they also look at deletions and duplications if needed. So the sequencing is all done up front. They only report off those specific variants, And then if needed, then they can go deep dive into the data and get it. So it really improves timeliness as well, that you're not having to do a panel and then if needed, have to send off sequencing afterwards. They reduced their false positive newborn screens, and the turnaround time really increased, especially for those that didn't have any variants in the panel. But unfortunately, this will still miss any babies who have 2 rare or de novo variants because of the need to have at least 1 variant on the panel to go further. So this is an interesting study from Germany. So they did a pilot study in their CF newborn screening. And what they did is for 8 years, they did simultaneously 2 different protocols that they evaluated. So what they did is they did their standard protocol, and then which was IRT, and then they looked at 4 different variants in their panel. And then they also then did IRT and PAP, which is pancreatitis-associated protein. And their goal was really to reduce the number of false positives that they were getting. So they did them in parallel, and what they found is for the IRT PAP, they identified 95 babies, 13 were by ultra-high IRT, but when they did their regular protocol, which is with the 4 variants, they identified 100 newborns and 5 by ultra-high IRT, and overall, they found that they really reduced the number of false positives, but they increased their missed cases. And I think this is really something to think about with any of those protocols. It is like a balance of how many are you willing to miss versus how many false positives are you going to get. And each protocol is going to be a balance of that and an adjustment of that when you're doing QI processes with your newborn screening. So this paper looked at factors that were associated with false negative newborn screens with either high IRT levels or low IRT levels. This paper came out only last week. So what they found is the false negative newborn screens that had IRT levels were associated with having Black race, newborn screening programs that had a higher IRT cutoff or having a fixed IRT cutoff, which correlates with those papers we started out discussing before, having less than 2 known CF-causing CF-TR variants, or having meconium ileus. Factors with false negative newborn screens with low IRT levels were associated with older age when they were collected, Saturday births, so delay in deliveries and processing, hotter seasons, like we talked about with climate change, preterm births, and then formula feeding newborns. So the important part here is that we need lower and floating IRT levels, but we also need better training for collection. And you can see how these are 2 very different set of problems that each need to be addressed to improve our newborn screening process. So now to move on to papers that discuss newborn screening outcomes. So this paper looked at longitudinal outcomes between infants born before newborn screening implementation and after. They found that newborn screens were associated with higher weight and height at 1 year old, and the graph on the top is the weight percentiles by age, that you can see the difference. Pre-newborn screen is in the turquoise, the yellowy orange is in the post-newborn screen group. Also associated with higher FEV1 at 10 years old, and that's the graph on the bottom. Older age at chronic Pseudomonas aeruginosa. So really the take-home point is newborn screening is associated with improved nutritional outcomes and allows for early treatments, including allows for early CF-TR modulators. So this is an interesting qualitative study of newborn screening for CF. So they interviewed newborn screening programs and CF centers, and what they did is they looked at the age of diagnosis by state, and they did the lowest quartile compared to the highest quartile to figure out what are the differences between these groups. So in this, you can see that communication is really key for timely diagnosis. So communication between CF centers, newborn screening programs, in both formal and informal meetings were rated as very important. Barriers that were identified is really the primary care doctors delaying referrals, poor communication with families, primary care doctors delaying referrals because they believe the only non-Hispanic white people with get CF, delays in sweat testing because infants were too young, too small, or being in the NICU. They also identified barriers of socioeconomic status, ability to take time off for work, transportation, newborn screening panels only using a limited CFTR variant panel, and communication barriers, language, cultural, and education, and once again, the myth that only white people can have CF. So now moving on to equity in newborn screening programs. This first paper compared the age of first event in newborn screen positive infants by race and ethnicity, and then compared to non-Hispanic white infants, Asian, Black, Hispanic, Native American, or mixed race infants had an older age at first events, and then they also had a lower weight for age at 12 to 24 months. And you can see the age at diagnosis, and then interestingly, there was also a difference on whether their first event was a sweat test or an encounter. It was dramatically different. So really, later evaluation of newborn screen positive infants may contribute to health disparities due to nutritional difficulties later on. This paper, let's see if we can pull it up. Sorry, too much animation that carried over. We looked at detection rate of CFTR variants used by newborn screen programs. So we looked at 8 different panels, and we compared by race and ethnicity. And we found that panels that had fewer CFTR variants performed very poorly in Asian babies, Black and African American babies, and overall poorly in Hispanic and mixed race populations. And you can see that if you look at the overall detection rate for any panel, it looks quite good in the high 90s. But when you break it down by race and ethnicity, they do very poorly, sometimes missing half of your babies in certain populations. Frankly, the ACMG panel is really unethical to use in any population besides non-Hispanic white, which doesn't exist in the United States. So we really need to be moving forward with expanded panels, expanded variants, and we'll be presenting this tomorrow morning as well. So special considerations for newborn screening in the age of CFTR modulators. I think this was just discussed this morning, and it's a really exciting place to be. So this is a case of a woman with CF who got pregnant 6 weeks after starting elexacaftor, tizacaftor, ivacaftor, and then just continued on therapy throughout her pregnancy. And the interesting thing with this newborn screening process is that the baby's IRT level was 37, which was below that state had a 5% threshold, and so had a normal newborn screen. Luckily, the CF team was on top of it. They contacted their state newborn screening lab, and they requested that the variants be sent anyway, and the baby was DEL 508 homozygous. So really important, as this is going to be more common, is to be discussing this and then talking to your newborn screening program of how you're going to do this, as more and more people with CF are going to be having babies on modulators. Let's see. So even more interesting is this was a mother who is a carrier whose baby was identified to have dilated loops of bowel at 23 weeks gestation. So starting at 32 weeks gestation, she started taking elexacaftor, tizacaftor, ivacaftor. And for this baby, the IRT level was 104, so triggered a positive newborn screen as well. So some of the take-home points for thinking about these cases is that CFTR modulators in pregnancy may lead to IRT levels that are low in infants, and then the cause a false negative newborn screen. But it seems like, since this mother, it was started later in life, this baby still had an elevated IRT level. So it'll be interesting over the next couple of years, as we start getting more case reports and hearing about this, is there an ideal time during pregnancy that we'll end up seeing that these IRT levels are going to lead to false negative newborn screens. And then really, once again, honing back in on like our basics is like all infants with a family member that has cystic fibrosis really need to have a sweat test and be evaluated to see if the baby has CF. And then timing, like I said, timing modulators are going to impact IRT levels. Otherwise, just an important message overall is just to be thinking about, as we're moving forward with the CF Foundation and our scheduling of all our future presentations and where we're going to be meeting, is we really need to think about protecting our vulnerable members of our CF community, our physicians, and really thinking about only being in states where there's reproductive freedom, gender-affirming care, and really the sanctity of physician-patient relationships. So. So otherwise, get out your apps, start putting in your questions, things that you want to discuss. We have a lot more coming up, and we're going to have a really good discussion afterwards. So sip your coffee and get energized for this. But I really thank everybody for being here. Thank you for the work and the care that you're doing with your patients. So
that was great. Well, thanks, Megan. That was a very busy year for newborn screening. So our second speaker, we're very fortunate to have Dio Cavallero-Otus from Emory University, who I believe is going to present the new CF Foundation guidelines for palliative care.
Good morning, everyone. Thank you so much for having me, and it's great to be back in person. All right. Wonderful. So for this presentation, we're going to take a little bit of a different spin. Instead of covering a variety of papers, we'll be covering the CF Foundation's 2021 recommendations on models of palliative care. No relevant disclosures on my part. There we go. So like I mentioned, so what we'll do today is give a little bit of an overview of palliative care. There's lots of misconceptions out there and misperceptions about what palliative care is and is not. So we'll start with a few definitions about palliative care, how it's typically delivered, and then we'll jump into, like I mentioned, the 2021 models of palliative care guidelines, walking through each statement one by one, talking about some considerations for you in your clinical practice and for your communities that you serve, and then we'll wrap it all up at the end there. So to get started, I like to make sure that we're all on the same page about what palliative care is and is not. Again, this is a term that is laden with a variety of different connotations and misperceptions. For the rest of today's talk, when I'm using the term palliative care, what I mean is an overall approach or a philosophy of care that is focused on improving quality of life and reducing the burdens of illness and treatment via a variety of different domains. When you look at most palliative care interventions or most palliative care clinical services, they'll focus on a variety of domains, and I've listed them here. So really thinking about expert symptom assessment and management, assistance with understanding what matters most to the people who we serve with CF in terms of their goals for care, their fears for the future, and making sure that we operationalize those goals and turn them into care plans. Providing psychosocial and spiritual support, making sure that we coordinate care amongst the constellation of providers that are working with people with CF, and all the while providing caregiver support, recognizing that in palliative care, one of our key mantras is that the family is the unit of care. Importantly, to make sure that we're again are all on the same page, when I'm talking about palliative care, I'm not referring to hospice care. So hospice care, just as a reminder, is a form of palliative care, a very intense and specific form of palliative care that is geared towards individuals who are at the very end of life, typically 6 months or less to live. For the rest of this talk, I'll be talking about early palliative care, so all of those same core domains, but delivered from the point of diagnosis onward. When we think about palliative care, we can think about two principal delivery models, and this undergirds the 2021 guidelines that I'll be mentioning in a bit. So really we can think about palliative care being delivered in two forms. The first and the most common is that of being delivered by a palliative care specialist, so somebody with a fellowship or other advanced training in palliative care principles. The other form, primary or generalist palliative care, is really this idea that any clinician, regardless of specialization, is able to recognize and attend to basic sources of suffering. So from a great paper published in the New England Journal in 2013, we can see this split out between primary and specialty level palliative care. And our guidelines cover both primary and specialty palliative care models. So like I mentioned in 2021, we were really excited to publish the results of about a 2.5, 3-year process spanning 23 interdisciplinary members on our team. And this brought together a systematic literature review, formative research in terms of qualitative research and survey research with our communities. And what we came out with a set of 11 guidelines you can see here split between primary palliative care, specialty palliative care, and screening guidelines. So to go ahead and get us started, actually I'm going to take a sip real quick. So, apologies there. So the first guideline that we have is regarding the role of primary palliative care. You can see the guideline or the recommendation statement here in blue. The CF Foundation recommends that CF care teams deliver primary palliative care as part of usual CF care at the time of diagnosis and throughout the disease course. So really this statement here stresses the importance that primary palliative care is a part of usual CF care. Many of you are already attending to basic sources of suffering and optimizing quality of life amongst the people that you work with. But really stressing the point that these are domains that should have attention paid to them throughout the entire course of someone's illness. And recognizing that these domains will require a team-based, coordinated approach. So every member of the CF care team has a role here, whether it is a physician, whether it is a nurse, whether it is a dietitian, everybody has a role here in providing this first-level palliative support. Our second statement here, the CF Foundation recommends that CF care team members receive primary palliative care training relevant to their discipline and employ those skills within their scope of practice. So here, again, we had done some formative research with the CF community and heard concerns that CF clinicians and care team members did not feel like they had some palliative care domains in their skill set. You can, if you go onto the CF Foundation's resources and in our guidelines paper, which I've cited and have on Twitter as well, you can see that we have a variety of toolkits and resources for individuals to get up to speed on basic palliative care competencies. The other point that I'll stress here is this quote of relevant to their discipline, again, reinforcing the notion that everybody on the CF care team has a role in optimizing quality of life. Our third statement, the CF Foundation recommends that CF and transplant care teams engage individuals with CF and their caregivers in goals of care discussions and advanced care planning across the lifespan. We know from epidemiological research that goals of care discussions are often delayed until the very end of someone's experience with CF. However, we also have qualitative data suggesting that individuals with CF are open to and will engage in goals of care discussions. Recognizing as well that goals of care discussions and advanced care planning tasks are not one-time static events, that those require an ongoing dynamic process that looks at one's goals, fears, wishes, and preferences and matches their care plans at that moment in time, and that those documents and those wishes will evolve over time. Our fourth statement, the CF Foundation recommends that CF and, if applicable, transplant care teams take a collaborative approach in offering comprehensive, timely, and compassionate end-of-life care, and to provide clinical expertise and support throughout the end of life. Recognizing that we have data that suggests that the use of hospice care is very low in CF, quite remarkably low. However, it is associated with higher quality of care when used. This recommendation statement supports increased use of end-of-life services like hospice care, but recognizes that there's a misperception that once somebody moves into the end-of-life stage, that they will be dropped off, that there will be a harsh transition between their primary care teams and hospice services. And instead, we recommend and suggest strongly that there continues to remain a collaborative approach, that CF care teams continue to stay the course with individuals that they've been working with for decades, and work with hospice care teams and palliative care clinicians to provide this bilateral exchange of information, both clinically and about the patient and their families, to ensure high quality, optimal, coordinated care even at the end of life. Again, reinforcing the notion that the family unit is the unit of care, we stress as well that caregivers may benefit from palliative support. So we recommend that CF care teams identify and address caregivers' concerns and provide support and resources outside of the CF care team when appropriate from diagnosis through bereavement. Again, recognizing that just as we screen for symptoms and quality of life concerns among adults or people living with CF, we also ought to be screening and attending to sources of burden and suffering amongst our caregivers and families. Moving next to the second set of recommendations regarding specialty palliative care. First statement here, CF Foundation recommends that CF and transplant care teams consult palliative care clinicians and other specialists to address palliative needs beyond their expertise, facilitating seamless communication pathways between and among teams. Again, thinking that palliative care is not often an event that requires a distinct demarcation between CF care and palliative care, but recognizing that palliative needs will come up throughout the course of one's illness, and recognizing that palliative care clinicians, for example, should be thought of as a resource that can be pulled at any point when extra support is needed. We also have some points that are specific sort of trigger events that really one should think about bringing in palliative care specialist services. For example, three points here are listed. So again, when unmet needs are identified that exceed the primary team's expertise, when transplant is considered or declined, and of course, when individuals with CF, their families, or clinicians request palliative care support. And again, we've talked about this a little bit before, but I'll stress it again. We recognize that once somebody starts receiving palliative care in collaboration with their usual CF care, that communication across those teams is very, very important to make sure that everybody is on the same page, that individuals and their families are getting the same consistent message, and that people are not feeling like they are quote unquote now palliative, but still receiving the same high quality CF care with additional support from palliative teams. Again, reinforcing the notion that the transplant process is a time when there are enhanced palliative needs. We recommend that specialty palliative care consultation occurs when an individual with CF is considering or when they decline transplant. Again, we have data that palliative care is very, very infrequently used in the CF transplant process and in transplant overall. But what we do know is that some of the potential benefits of involving palliative care specialty services in the transplant process, both pre, during, and post, might include improving or stabilizing someone's symptom burdens and their other concerns, again, throughout that trajectory, addressing expectations regarding survival or what life might look like after such a procedure, and addressing and resolving any conflicts among families, individuals with CF, and their care teams regarding the goals of care, both before and after transplant. All the while, we again recommend that while somebody might involve a palliative care specialist in the care of somebody living with CF, that again, there is seamless communication amongst these teams, recognizing that palliative care clinicians may not have had much exposure to somebody living with CF, might not understand the state-of-the-art therapeutics in CF. We recommend that CF care teams, again, provide some sort of bilateral informational exchange or some expertise to palliative care team members to make sure that palliative care team members are not suggesting something that is out of line or not suggesting something that might be going against years of relationship between the CF care team and that patient and their family. Last but not least, we recommend screening and assessment of palliative needs. I'll go through this pretty quickly. There's a very, I wouldn't say complicated, it is a detailed diagram or flow chart in our manuscript published in the Journal of Palliative Medicine regarding screening recommendations. But you'll see here we split them out into 3 categories. So for individuals who are ages 12 and above, we recommend something called the Integrated Palliative Outcomes Scale. And that's available freely online, as well as through our resources that we've pulled together. We recommend that annually and at specific disease milestones, which again are defined in our manuscript. For individuals who are 12 years of age or younger, we recommend the IPOS instrument again, but not necessarily in the same fashion. We recommend it more thematically as a guide for conversations. And for caregivers, we recommend annual screening using the BASC or the Brief Assessment Scale for Caregivers. So to pull this all together, again, we have 11 recommendations in this manuscript published in 2021 in the Journal of Palliative Medicine. But key points here, to reiterate again, is that palliative care is relevant throughout the entire CF experience. We should not be thinking of individuals turning into a palliative patient, for example. We should be thinking about how palliative care, both primary and specialty, can be integrated throughout the CF experience and scaled up or down based on that person's needs over time. CF care team members have a key role in identifying these needs, both on an annual basis as well as PRN as needs fluctuate throughout the course. We again recommend screening and assessment using a variety of tools, but we also recommend individuals lean in a bit more into some of these domains that we've talked about before in their usual clinical practice. We also recognize and have pulled together resources to enable and empower CF care team members to beef up some of their primary palliative care skills, whether that is basic symptom assessment and management, whether that is how to start a conversation about goals of care, and when to recognize when somebody might have concerns that may indicate referral to a palliative care specialist, a pain service, a chaplain, whatever that domain is and whatever that clinical specialty is to match that need. And last but not least, we recommend again that palliative care specialists should be involved early and as needed. That a palliative care specialist may not be required for the entire life course, but will come in whenever there are points when somebody's needs may fluctuate up and might dip out when somebody's needs fluctuate down. But again, palliative care specialists being leveraged whenever that need is indicated or whenever that patient's need expands beyond the competencies and the confidence of their primary CF team. And last but not least, none of this work would have been possible without our multidisciplinary team in pulling these guidelines together. And like I mentioned, I have these guidelines on my own Twitter profile, and they're also published in the Journal of Palliative Medicine last year. Thank you so much.
Thank you, Dia. That was really good. So for any of you that came late, there is the question app on your phone in the program, and we've already started to get some very excellent questions. So feel free to go ahead and continue to enter these questions, and then the speakers themselves will answer them at the end. So our third presentation today, Jonathan Koff from Yale, who is going to give us the year in review on phage therapy.
I'll knock everything down before I'm done. All right, wonderful. Well, thanks everyone. Appreciate the invitation and opportunity to speak. And I'm going to talk with you about phage therapy. And I'm going to start with some disclosures that I think are important just for me to mention as I get this to move. So I'm at Yale, and our institution has licensed intellectual property to a company. I don't have any financial association with that, but I need to mention it. And then I'm also a primary investigator on a sci-fi study for phage therapy at Yale, which I'm going to talk about, and also have a role with the Biomics trial that's going on through the TDN. And what I want to do today is really take an opportunity to talk about bacteriophage biology very briefly, but with the lens towards how some of the biology is really informing what we consider phage therapy. I'm going to define for you phage therapy and talk about the process for that to occur, and then highlight for you a little bit of the history of phage therapy in CF and our more recent history that has highlighted phage therapy as a potential opportunity for our CF patients, with non-tuberculous mycobacteria being a great example, and then talk a little bit about some of the other gram-negative bacteria that are pathogens in CF sputum. And I'll finish with some really exciting clinical trials that are ongoing, and I'll just give you a snapshot for those in terms of what's available from clinicaltrials.gov. So bacteriophages or phages are viruses that infect specific bacteria, and so they're considered bacterial parasites. There's evidence that phages can very selectively infect certain bacteria. But I also highlight for you, there's no evidence for any type of receptor on human cells, but there's increasing recognition that as our cells in the lung and in other organs sample the environment, they're probably picking up phages as they pick up other particles that they're sampling. First discovered in 1914 by Englishman Dr. Twort, and then Felix Jarell in 1917. And as you can see here, I've highlighted that there are an enormous number of phages in the environment. So there are more phages on the planet than any other organism. People describe, look at the stars in the sky, more phages than stars in the sky. But importantly, I would highlight for you that phages are found everywhere you're going to find bacteria. So gut, sinuses, in the lungs of our patients who have infections. And most importantly, phages outstrip bacteria about 10 to 1, which suggests we should be able to go out into the environment and find a phage that could target and kill a specific bacteria of interest. And then I'm highlighting for you the lytic cycle here on the right. Is my cursor showing up? Where a phage is going to bind to a specific bacteria, enter genetic material, and you're going to see it's going to hijack the cell infrastructure to process and produce progeny. And then this lytic part is very important, where you can see here that a single phage is going to self-amplify, disrupt the bacteria, and allow for self-replication and this progeny to be produced. That's important when you think about kind of dosing considerations, right? A single phage can produce multiple, but also the potential here to limit the ability of phage to provide genetic material to the bacteria to make them more virulent. And that's been described for the lysogenic phages, and we want to stay away from that, obviously, when we're thinking about phage therapy so that we don't increase the virulence of the bacteria that we're trying to treat. Some characteristics about phage that I think are very important. Phages have been shown to produce enzymes that disrupt biofilm. They're also been shown to be stable on the biofilm and mucus layer while they kind of wait for bacteria to show up and then are able to infect bacteria and then again self-amplify in that environment. And those are characteristics that can be very useful for us when we think about treating with phage therapy in CF. The specificity of a phage is really interesting. It highlights the potential for personalized medicine, right? You have a bacteria like Pseudomonas or Mycobacterium abscessus in the lung. We should be able to find a phage that is specific to the bacteria that we think is problematic. And that personalized approach, I think, is really exciting because it's very different than we currently do with antibiotics. And so from a kind of history of phage therapy, it's an obvious kind of idea of the enemy of my enemy is my friend. I'll highlight for you that Felix Jarell has a lovely connection at Yale. He was on faculty in microbiology before he then went to Europe and specifically to Tbilisi, Georgia, where he worked with Dr. Eliava. The Eliava Institute is named for Dr. Eliava, and there Dr. Jarell and Dr. Eliava actually started phage therapy on patients. They, as you can imagine, took the phages themselves to make sure that they were safe and then started treating patients. I don't speak Russian, but there's a tremendous amount of literature in Russian from work that's been done at Tbilisi at the Eliava Institute and in other programs. And you can see here that there's over 350,000 cases reported from folks that have translated some of this literature. I'll highlight for you there's clear limitations where we have to think about problems with standardization, purification, how they reported efficacy. But importantly, we get a lot of information on delivery of oral, IV, and rarely nebulized phage therapy. And the approaches were to use a single phage for multiple bacteria at the same time, and then also cocktails for a specific bacteria or multiple bacteria. And a cocktail would be defined as more than 2 phages for the same bacteria. So when we think about phage therapy for CF, now with Trikafta, it's a little, less easy for us to get sputum from our patients, but certainly when we're thinking about treating a CF patient for the colonization of the pathogen that they have that's probably causing their pulmonary exacerbation, sputum is our source, and you can take that sputum, grow up the different bacteria in the laboratory, and you can see here a lawn of bacteria that's grown in culture, and we take our phage library, and individually you can test phages to see if they're going to cause these plaques or lysis. And you can see here an example of where that doesn't work. And this can also be introduced into a much more high throughput system using robotics to test multiple different cultures using your library of phages. So there's a high throughput component to this. On the right, I highlight for you programs in the United States that I'm aware of that have participated in either identifying phages for phage therapy, helping out in the process of purifying these phages to meet FDA standards, treating patients, and also providing guidance in terms of route of delivery and obviously also treating on-site or helping other institutions to treat their patients. And so this has seen an enormous growth in programs around the country, which is really exciting. So when I looked at the literature, you can see here, just with a PubMed search in English, we're seeing a large number of papers that are coming out about phage therapy specifically. I'll highlight for you that the review articles are typically saying, hey, here's a case of phage therapy, and now we need to consider a lot of things specifically to how we want to do this in CF. The animal models and cell culture models have been very informative to test the efficacy of a specific phage against bacteria in a lung infection model, for example, but also to look at the characteristics of how the phages influence bacteria in the cell culture system, and that gets into the potential associations with disruption of biofilm and also being able to work with a thickened mucus layer. Nebulization is really interesting as we think about ways to improve stabilization of the phage with delivery. I think this is really with folks thinking about how this can also happen in the GI tract, right, where you can or take phages orally to and survive in the acidic pH in the stomach. That's probably less relevant for CF unless we're thinking about really trying to target the microbiome in particular ways, but I think it's really for consideration for other diseases. And then I'll highlight for you the case reports and case series. And I'd like to focus on this to show how we've learned so much about phage therapy that's really informed what we're doing for the clinical trials that are ongoing. And so on the left, you're going to see here work by Dr. Diedrich and Dr. Hatfill at the University of Pittsburgh. I think they did a fantastic job of really highlighting their process for single cases of phage therapy. These are often called expanded access or emergent INDs that require FDA approval. And here you're seeing that they screened 200 isolates and were able to find phages for 20 of them. So highlighting one of the issues for treating M. abscessus in particular, which is that we have phages that can be quite effective, but unfortunately they're not broadly effective against isolates. And this highlights the need for continued techniques to explore the ability to provide for a broader treatment effect. These cases all of them were phage cocktails, and they, I think, started off with IV administration and then also transitioned into using some IV and inhaled treatments. And those were seen and described as safe in terms of patients tolerating the administration, and in some cases, very effective. And on the right, one of the examples here by Dr. Nick and colleagues who treated a specific patient. And this cartoon may be a little small, but I think it really highlights a great example of understanding the interactions of the phage with the mycobacterium and also the host response. And so we have a patient here who's had longstanding M. abscessus that was recalcitrant to therapies and prevented the patient from being considered for lung transplant. And so moved forward with phage therapy here and saw a significant decrease in clearance of sputum M. abscessus, which allowed the patient to be considered for lung transplant, and they went forward with lung transplant. And so that's a success into itself. But in addition, by looking at the characteristics of the phage bacteria interactions, they're able to show that there was no evidence of resistance developing when this patient was treated for an extended amount of time, which is, I think, a really interesting characteristic about treating Mycobacterium abscessus in particular. Oops, sorry. And the other part to this is that by carefully looking at the host response, the patient response, there were evidence of antibodies being produced against the phages that were being used for treatment, but the phages were still effective. And so that highlights that while we can look for these antibody responses, I think we need a lot more work to better understand how this interaction is going to occur and in terms of are there going to be consequences to treating our patients. So then I have a particular interest in phage therapy for Pseudomonas. I tried to kind of scour the literature for the first example of nebulized phage therapy for CF. And I think I found a case here described in publication in 2008, and it was included in this publication in 2011 that described, again, in the Russian literature, two children being treated with nebulized phage for Pseudomonas. Since then, we've got an example with the IPATH group at UCSD, led by Dr. Aslam here, who treated a patient with phage therapy in conjunction with antibiotics and reported a good outcome for this patient. And we're trying to contribute to this field, and so we've summarized our first 9 cases of phage therapy for multi-drug resistant or pan-drug resistant Pseudomonas at Yale. This has been submitted for publication, and I'm going to highlight for you that my colleague, Dr. Gail Stanley, is going to be presenting this work on Friday. There's a poster up this afternoon, and so to give you kind of just a rough description, we have our 9 patients who receive phage therapy, and we're looking at sputum after phage before and after phage therapy, and we're looking at around 2 weeks after the completion of the phage therapy, and you can see this decrease in the amount of bacteria present in the sputum, which is encouraging. We also saw an improvement in FEV1. All these patients were prior to Trikafta. But interestingly, that regardless of their starting FEV1, they did see a little bit of difference. And and in the group that had FEV1 greater than 40% predicted, there was obviously a marked change in their FEV1. And what we're highlighting in this last diagram here is the potential for a different type of strategy for phage therapy where we're actually trying to drive resistance of the bacteria. So you can see here before phage therapy and after, we're pushing resistance. And we're doing this intentionally because we've identified phages that bind to specific virulence factors on bacteria. And by driving resistance and targeting virulence factors that are associated with antimicrobial resistance or inflammation that the bacteria would generate, we're able to change the surviving bacteria into those that are more sensitive to antibiotics or produce less inflammatory stimuli in the lung. And Dr. Stanley's going to have much more detail about how this can work to our advantage when we treat patients, and in particular, some of the important differences that we found between a single phage approach and a cocktail approach. But I think what's also really interesting about Pseudomonas is its ability to really continue to generate resistance to phage. And so strategies to continue to find phages are going to really be important to us in this community. And I want to highlight these 2 papers, one in the States at Pittsburgh and the other in Australia, where these research teams are going after strategies to identify phages that are going to work against clinical isolates of Pseudomonas from CF individuals with cystic fibrosis. I thought the strategy from the group on the left was brilliant. They took the wastewater from one of the local hospitals to identify phages against Pseudomonas, right? So thinking, I think quite cleverly, that there's probably a lot of Pseudomonas in the institution. And so they identified these phages and also did a fantastic job of characterizing them on the genetic level and looking at clinical isolates and the interaction. And they also went on to show that these phages are going to disrupt biofilm in addition to being able to kill the clinical isolates of bacteria. And so these approaches, I think, are really, really beneficial to the field as we identify phages that we can potentially consider for future therapy. And I'll highlight for you some of the differences between where we are with Pseudomonas and then where we are with Achromobacter. And here, I can only find 3 cases of treatment of Achromobacter in children or adolescents with CF using an inhaled approach or inhaled combined with oral. I think what we're missing is the denominator, but also I get the sense that we don't have as much information about phages that are available for Achromobacter, and this is obviously a pathogen that we're seeing with potentially increased frequency in our CF patients. So more work to be done here. And then I'm going to conclude with some really exciting clinical trials, and I just want to highlight these for you. They're all available on clinicaltrials.gov. The first one, I'm doing this just in terms of when they started. So the Armada trial has a great name, SWARM PA, was started in December of 2020. It's a multi-site trial, and all of these are very similar in their randomization, blinding, and I'll just highlight some of the differences. So this trial is looking at inhaled phage cocktail and using, and really that's a strategy that Armada started with, which I think really informed the field. Our approach at Yale has been different. We started the trial after in March of 21, and here we're using a single phage based upon some of the strategies that we're thinking about in terms of generating trade-offs. And in this, it's a single phage that's nebulized, and we happen to have an open label arm, which is a little different than some of the other trials. Biomics trial just started earlier, this is in June of 21, I apologize. And they have multiple sites around the country using a phage cocktail approach with two parts where they're escalating the phage doses. And this trial just started, sponsored by NAID, so I heard from a colleague that several patients have recently been enrolled, and this particular trial is interesting because it's an IV approach to phage therapy, which I think has some interesting potential for consideration. And so that'll be exciting for us to see. And with that, I'd just like to thank my colleagues at Yale. We have a Center for Phage Biology and Therapy started by Dr. Turner, who's just a pioneer in phage therapy, in phage biology, and has been a real joy to work with. And then my colleagues and collaborators in that program and in our adult CF program. Thank you.
Thank you very much, Dr. Koff. So last but not least, I'd like to introduce Dr. Kathy Ramos, coming to us from the University of Washington, who will be speaking on lung transplant and CF.
Thank you very much for the invitation to speak. I'm so happy to be here and happy to be back together. So I have some grant funding to disclose, though it's not directly related to what I'm presenting today. So I will talk about 4 different subjects. First, the effects of elexacaftor, tezacaftor, ivacaftor, which I will henceforth call ETI, on lung transplantation for CF, inequities in access to lung transplant for CF, the new ISHLT, or International Society for Heart and Lung Transplantation, recommendations for referral and listing of people with CF and advanced lung disease, and then ETI after lung transplant. So to start, I want to present this article that was in the Blue Journal by Dr. Burgle and the French group that showed rapid improvements after starting ETI in patients with CF and advanced lung disease. This is a prospective observational cohort study at 47 CF centers in France, and it included patients between December 2019 and August of 2020, with follow-up through September of 2020. It included people with CF who were aged 12 years and older and had an FEV1 less than or equal to 40% of predicted, and clinical data prior to ETI initiation and 1 to 3 months after ETI were included. And the outcomes of interest are listed here. It included FEV1 change and weight change, as well as a change in the need for supplemental oxygen, non-invasive ventilation, or enteral tube feeding, and then the outcomes of lung transplant, death without transplant, or alive without transplant. So they had 245 patients with advanced CF lung disease who initiated ETI, 228 of whom were adults. 76% of these patients were not on other CFTR modulators at the time of ETI initiation. The median follow-up was 84 days, and adverse events were generally mild and consistent with the rates that are reported in published RCTs. 53 patients, or 22%, were on the lung transplant pathway, as they called it, at ETI initiation. 16 people were listed for transplant, and 37 were undergoing evaluation at the time when they initiated ETI. So what they found was an absolute FEV1 improvement by an average of 15.1% at a median of 73 days after starting ETI. And the people who were on supplemental oxygen or non-invasive ventilation had lower than the median FEV1 response. The absolute weight increased by an average of 4.2 kilograms. And what you can see here is that the proportion of patients who required long-term oxygen, non-invasive ventilation, or enteral tube feeding all decreased from the time of initiation to month 1 or 1 month after, and also again to 3 months after initiation. There were also reduced rates of transplantation and death. So what you can see in the middle column is that at initiation of ETI, about 15% of their patients were already referred for transplant, and 6.5% were on the transplant list. At the end of follow-up of the 245 patients, only 1 person was referred for transplant, 4 people were on the lung transplant waiting list, 2 underwent transplant, and 1 person died without a lung transplant. There was a more than 50% decrease in the number of transplants for CF in France in 2020, and most people who died or underwent transplant in 2020 did not receive ETI. There have been additional studies that support these initial findings. So there was this paper here in JCF by Birmingham, and they showed in a retrospective cohort study at 3 CF centers in the US that the mean FEV1 change was 7.9% at a median of 39 days after starting ETI in this advanced lung disease group, and there was a decreased number of people that they considered eligible for transplant referral. Additionally, in France, they submitted this correspondence to the Blue Journal, and they showed that the transplant numbers and deaths without transplant remain decreased into 2021. For some reason, this is not yet published, but hopefully soon. I show this data often. This is publicly available data from unos.org, and what you can see here is that up until 2019, CF patients were approximately 10% of US transplants each year, but in 2020, that dropped down to only 78 transplants, which was 3% of the US transplant population, and in 2021, it was less than 2%. And so for patients in whom exacerbations may have been driving their move toward lung transplant, ETI may have had even bigger effect on the timing of transplant. And then as of September 30th of this year, only 23 transplants for CF have happened in the entire country. And so if you project that out to the end of the year, we're probably going to end up low 30s or maybe less for the entire country, which is amazing. So I want to shift gears now and talk about the impact of socioeconomic position on access to the US lung transplant waiting list in a matched CF cohort. This is Dr. Lair's group from Cleveland Clinic, and it was published in the Annals of ATS in November of 2020. They did a case control study using the CFF patient registry linked to the SRTR data, the Scientific Registry of Transplant Recipients. People aged 18 years and older between 2006 and 2014 were included. Cases were people who were listed, who were waitlisted for lung transplant. The controls were not waitlisted, and they did a 1-to-1 matching for age, FEV1 that they categorized, and calendar year that they also categorized. And they created a CF clinical health score and a socioeconomic barrier score. And then they calculated the average change in probability of waitlisting from 50% for each dichotomized factor in a logistic regression model. And they said that people had a 50-50 chance of being waitlisted because 50% were waitlisted and 50% were not waitlisted at the beginning, and they were matched. So their CF health score included 9 items: sex, supplemental oxygen use, BMI, hemoptysis, FVC, MRSA, multi-drug resistant Pseudomonas, non-tuberculous mycobacteria, and days on IV antibiotics. And the socioeconomic barrier score included 7 items: the race and ethnicity, marital status, highest education level, employment, insurance type, census-based median household income and their 5-digit zip code, and the distance to the nearest lung transplant program. They found 1,555 waitlisted patients and matched them to 1,555 unlisted patients. And what you can see on the graph here are that the individuals were evaluated for their change in the probability of being waitlist, grouped by their CF health score, which is on the x-axis, and their socioeconomic barrier score, which is the blue squares and the green dots. And so the green circles indicate individuals with a higher socioeconomic barrier score, therefore they have more socioeconomic position barriers, and the blue squares indicate people with the lower score. And what they found was that within SES category, those with the higher disease severity were more likely to be listed. So that's consistent with what you would expect. But the individuals who have an intermediate CF health score, so less severe disease, and low socioeconomic barriers were more likely to be waitlisted than the sickest individuals with high socioeconomic barriers. So sicker people who have socioeconomic barriers are less likely to get waitlisted than people with less severe disease but lower socioeconomic barriers. So there's clearly a problem there that the sickest people are not getting to the wait list. So shifting gears again, there are new ISHLT candidate selection recommendations that were published in the Journal of Heart and Lung Transplantation in November of 2021. And in this document, early referral was reiterated to the transplant community. So this is in the CF Foundation lung transplant referral guidelines, and again in the transplant community in this document, it was reiterated that early referral is really important. Risk factors associated with worsened survival after transplant were highlighted, and so there are there's a categorization of how severe different risk factors are and what level of risk each factor poses. And transplant candidate selection was considered in an ethical framework, thinking about the balance of the scarce resource as well as the individual versus the community need for lung transplant. Because if you had unlimited organs and you had a person who's dying from their lung disease, you'd want to transplant every single person, even if they only lived 2 months after their transplant. But if you transplant people who are likely to die very soon after their transplant, then it's not only their life that is lost, it's another person who could have potentially benefited from those lungs. And so we really thought about the fair innings rule, thinking younger people ought to be prioritized for getting lungs. Unfortunately, the rate of CF lung transplants has plummeted, as I showed, but just thinking that in the future, if there is a waning effect of Trikafta, how can we prioritize getting lung transplants for people with CF who are still going to be much younger than the average person who gets a lung transplant? And then there were some disease-specific recommendations as well, and I'll just highlight the CF-specific recommendations. Optimal medical management, including a trial of ETI if the person is eligible, was included. And then the referral recommendations mirror the CFF recommendations almost exactly. And then the listing recommendations among those who meet referral criteria included when somebody's FEV1 is less than 25% of predicted, if there's a rapid decline in lung function, including a 30% relative decline over 12 months, frequent hospitalizations, any exacerbation requiring mechanical ventilation, and this is in the group with advanced lung disease, chronic respiratory failure with an increasing supplemental oxygen requirement or the need for non-invasive ventilation, pulmonary hypertension, worsening nutritional status, recurrent massive hemoptysis, and WHO functional class 4. So these are recommendations, and they're not based on strong evidence in the ETI era because we don't have that evidence yet. It hasn't been quite long enough, but this was the expert consensus from an international group. So the last section is about the use of ETI among CF lung transplant recipients, and this paper was published in JCF in October of 2022. And so this was an electronic health records-based cohort study between October of 2019 and September of 2020, and 15 CF lung transplant consortium sites were included, and one of those sites is is in Toronto, and so they didn't have access to Trikafta during this time period, and then 3 of the centers in the United States also didn't prescribe Trikafta to any of their CF lung transplant recipients during this time. And so there were 95 CF lung transplant recipients who were prescribed ETI after lung transplant within the CF lung transplant consortium. And there was a lot of variability across the 11 CFLTC transplant programs who prescribed ETI. And what you can see on your left-sided y-axis is the number of CF patients in the program, and then the orange line shows the percentage or proportion of the CF lung transplant recipients who were prescribed ETI. And so there was really wide variability. At the high end, a third of their patients were prescribed Trikafta after transplant, and at the low end, no one in 3 programs in the US was prescribed. And so we looked at the indications for prescribing ETI after transplant, and sinus disease was by far and away the largest indication, but GI symptoms came in second. Low BMI was also a factor for some, and considering retransplant came up a few times. Patient preference to try ETI was present in 45% of cases where ETI was started. So there were some challenges with the use of ETI in the CF lung transplant consortium, though immunosuppression management was challenging for only 4 out of the 91 patients who actually started ETI. 4 of the 95 who were prescribed ETI didn't start it. 1 person died before she got the medication. 2 people decided they did not want to have lab work during the pandemic, and 1 other person, I can't recall what happened to them, or they got retransplanted before they got the medicine. That was the other issue. So 91 out of the 95 people who were prescribed ETI started taking it, and 4 people, there was some trouble managing their tacrolimus. And what that meant is they just had to have multiple blood draws to get their TAC into the right therapeutic range. But one difficulty is that the clinical effects of these drug interactions on ETI levels is unclear because there's no clinical lab measurement of ETI available at clinical institutions, and so we don't know whether people had very high levels of the components of ETI or very low levels. Maybe that's part of why they either had side effects or felt no effect. And so many people actually, of the 91 patients, 39 of them, which is 43%, stopped taking their ETI during the period of the study. And the main reason people stopped was GI symptoms. So 7 people had either nausea, vomiting, or diarrhea, and then 4 additional patients had abdominal pain. So 11 out of those 39 people stopped because of GI symptoms. Some people did have cough, congestion, worsening shortness of breath, and there was 1 or 2 patients who had the shortness of breath and cough, and they stopped ETI and they restarted it, and the symptoms recurred. And so I believe that some people really did experience that when they started ETI after transplant, and then sort of a smattering of other reasons to stop. So the clinical outcomes within the CFLCC cohort are shown here. Some patients experienced clinical improvement, increased BMI for people with low BMI, though that was not statistically significant and it was a small sample size. There was an increased hemoglobin, which was most notable for those with anemia, decreased hemoglobin A1C, a reduced use of antibiotics, and also a reduced frequency of symptomatic acute cellular rejection. But I am cautious about my interpretation of the reduction in the use of antibiotics and acute cellular rejection because it overlapped with the beginning of the COVID-19 pandemic, where we stopped doing screening bronchoscopies or surveillance bronchoscopies to look for rejection. And even if people had symptoms, they were less likely to get a bronchoscopy because of the pandemic. And so we don't have any sinus or GI symptom metrics from this cohort. We did ask the physicians, and they reported that patients seemed to have improvements in their sinuses, and some people had improvements in their GI symptoms as well. And we know in the non-transplanted patients that the sinus effects can be really profound. There's indication bias present, which may have confounded our results. At some institutions, only the very sickest or worsening patients were prescribed ETI as they were considering retransplant, as they had chronic rejection of their lung transplant. And COVID-19 limited the in-person clinic data, and we were also limited about bronchoscopies, as I mentioned. And there's also no control group in these data either. It's just the people who are prescribed Trikafta and its pre and post ETI measurements. So there are some potential indications for ETI post-transplant, sinus disease and sinus symptoms, low BMI or malnutrition. I didn't really emphasize the CF-related diabetes data that much, but the hemoglobin A1C improved significantly in this group, and any of the above indications in combination with CLAD or consideration of retransplant. For people who have GI symptoms, GERD, a potential change in their risk of malignancies, osteoporosis, depression, these are things that have been raised in case reports of people who were post-transplant and started on ETI. I thought that maybe some of these other things may have changed by starting ETI. And so the potential pitfalls for using highly effective modulators post-transplant, presumably there's no effect of CFTR modulators in the donor lungs. The drug interactions can be significant. There are side effects of ETI that may lead to starting and stopping ETI, which has implications for immunosuppression management, and then the cost relative to benefit. So in conclusion, the timing of lung transplant for CF has become more complex. Some people treated with ETI may never need a lung transplant, but there's really an unpredictable long-term trajectory for individuals who are on chronic ETI, though the early data is promising. Racial, socioeconomic, and geographic disadvantages exist for accessing lung transplant, and there is a risk of exacerbating these already existing disparities. Fewer centers will have expertise in CF transplants, and non-white Hispanic CF populations are less likely to have access to ETI. Early referral to lung transplant programs remains important, and the use of ETI after lung transplant still requires further study. That's it. Thank you.
Thank you very much to Dr. Ramos. So next we have about 40 minutes for discussion. So thank you for all those of you who have put questions into the app. Also feel free, if anyone has questions in the audience and prefers to ask directly, there is a mic right here, so feel free to use that. So I'll start with the first question, which will be for Dr. McGarry. In adults, sweat chloride normalizes quite substantially with effective modulator therapy, depending on the mutation. Should we be offering genetic testing directly instead of any functional testing like sweat chloride or IRT in infants with a high clinical suspicion for CF with mothers who took modulator therapy while pregnant?
That's a great question. So I think that the answer is time will tell. But if the sweat is normal, should not be reassured. So I think that the sweat might be useful and maybe you'll get a quicker answer than if you're having to send off genetics. But that if your sweat is normal, you should still send off genetics. So I think this will probably end up with guidelines on how to manage these babies. But definitely suspicion should be very high. And there should actually be a plan in place to discuss ahead of time with the family, with the care team in the hospital, so that way everything would be pretty seamless. And hopefully, if there, that you would be able to intervene once again before there's any weight loss or any malnutrition.
Thanks, Megan. There's one other question. Why don't you address from Greg Zwicky? Thinking about limited resources for NBS programs, should we advocate for focusing on IRT and referral for sweat or on an expanded genetic panel for newborn screening?
Yeah, so I think that these next couple of years there's going to be a lot of pressure in balancing out what would be our most ideal public health program for newborn screening versus what our reality is in this environment. So public health departments have been really depleted of resources, depleted of people over the last couple of years, and especially depending on how elections go this year and in 2 years, maybe even further depleted. So there may be states where you have to go with IRTs as your main thing, and any IRT elevated needs to get sweat tested because the finances in your public health department and your newborn screening program are not going to allow you to do further genetic sequencing. The CF Foundation is working on this, and there'll be guidelines hopefully coming out next year about newborn screening programs, how to do equity. So hopefully then you'll have some guidelines so you can go back to your state representatives, back to your public health departments to say we're not meeting our, what the recommendations are that can give you some backbone. But I think there's going to be states where there's going to be actually a lot of pushback. And so I think there is going to have to be a lot of attention and a lot of discussions with your public health department about what you're going to do with the resources that you have, while you're also advocating for resources. Another thing is that to find out who it is in your public health department that's managing your CF newborn screen, it may be somebody new. There's a lot of people who have left. This may be a time to engage and start these discussions, but great question.
So next we'll ask Dr. Koff to come up. We've got a couple of questions here. So the first question, how long does it take to identify a phage cocktail for a patient? Will there eventually be a more generic cocktail of phages against an organism that could be more widely used empirically rather than needing to wait for a tailored phage to be identified?
Yeah, those are good questions. In our laboratory, phage can be identified basically as quickly as the bacteria is required to grow. So in some cases, for a patient with Pseudomonas, for example, where we get growth over 3 days, we can identify phages within that window, and sometimes even faster as the Pseudomonas is growing. But a more slow-growing pathogen, it can take longer, and we've obviously had examples of that. I think the cocktail question is really interesting. I'll take an opportunity to just highlight a couple of points to that. The cocktail is really going to be dependent on recognizing whether or not you're using phages that are binding to the same receptor. So, for example, a lot of the phages that are out there are targeting polysaccharide or LPS, which is widely distributed on bacteria like Pseudomonas, if you use that as the example. And so using a phage to target LPS, or multiple phages to target LPS may do
great job of decreasing the amount of mucus that's there. But the bacteria do have phenomenal skills in trying to change that receptor site in order to survive. And so there is a potential that the cocktail can actually increase resistance more broadly. There's also, I think, some concerning data to suggest that getting multiple phages into the same bacterial pathogen really causes some inefficiencies in phage replication, where, as you can imagine, the phages are trying to hijack the bacteria to replicate. And so in the context of that, the cocktail may also be limited. And then I think the third part of the cocktail discussion is the potential to actually increase virulence. There is evidence that as cocktails are targeting potentially multiple different receptors, the phages are actually, the bacteria are, and in particular, we have evidence in Pseudomonas and E. coli that bacteria are starting to replicate and the survivors are inducing spontaneous mutations. And so the possibility of a more virulent bacteria actually occurs. So I think we actually have equipoise for consideration of whether cocktail is really the way to go. And I think the interesting aspect is that a generic cocktail might work for a period of time to target a lot of Pseudomonas in the community. But I think we have to expect that cocktail will unfortunately stop working for bacteria like Pseudomonas. And I think we might want to consider a strategy where using pieces of that cocktail longitudinally over time might be just as effective and potentially more effective long term. And so I understand the interest on the industry side to produce a cocktail that's going to work for everybody. But I also think that is likely what we've seen with antibiotics, right? And potentially even faster, where the bacteria are generating resistance to antibiotics very quickly. And I think we should expect the same thing to happen potentially for phage cocktail in that context. So I think this is going to be one of these challenging discussions as we try and move this from single cases to something that can be FDA approved. But I think there is the potential for a library of phages, which has been suggested for both individuals and groups interested in a cocktail and single phage approach to be approved. And based on that library, you can then deploy specific phages. And so the issue is just going to be the production of the phage and stability of the phage long term to be able to then treat your specific patient. And so I think there's a balance there that needs to be struck, and I think we're in the beginning stages to understand that. So it's a great question.
Thanks, John. Why don't we ask another question? There was a question here about the safety of phage for people under 12, but what about the appropriateness of phage for very young people? Should phage be saved for later in life, or is phage best early in life?
That's a great question. I think from a safety perspective, all we have are these single cases. Typically, what I've seen are very symptomatic patients and who are struggling with current antibiotic use. I think studies are going to be required. There's no evidence that phages would be any different in a pediatric population versus an adult population if there is Pseudomonas in the lung, because we know that there are phages there. But I think those studies have to be done and should be done in parallel. I think saving phages is an interesting idea, but I'm leaning towards actually potentially considering earlier use of phage, because I think it can help us with eradication techniques and potentially improve the ability to eradicate Pseudomonas, for example, in our children, like the EPIC study, right, where we tried to do that with antibiotics. And in synergy with antibiotics, and potentially, like I described, a longitudinal approach, if it can be shown to be safe, could actually be more effective and allow for us to actually save antibiotics, right, which is actually another pandemic that we're going to run into, unfortunately, by projected by the year 2050, where we're just going to have patients dying because of lack of effective antibiotics. And so I'm obviously really interested in trying to pursue a clinical trial in a younger patient population so that we can show some evidence. But I think there probably is going to be, like all studies, ranges that we start lower and lower. But I think the studies can be done and will help us identify safety.
Thank you very much. Next, I'm going to ask Dr. Cavalieretos up. So this question came up by a few people. Can you recommend training sessions or CME options to enhance the skill set of the multidisciplinary CF team to provide primary palliative care? So that came up by a few people.
Absolutely, great question. So, like I mentioned, we have some resources published on the CFF Resource Library, NACFC. I can take a look there. There's a number of guides there. And then there's a number of other resources. For example, there is an Indiana University School of Medicine series that's in production right now. It should be going out soon, hopefully. The Center to Advance Palliative Care also has a number of free modules. If your institution subscribes to them, those are also available. The other thing I want you to know is we're just yet, although you can probably reach out to the investigators and ask for them. So there are 2 ongoing studies funded by the CFF looking at the role of palliative care. One that I'm the PI of, and we've developed modules related to palliative care training for the entire team. There's another study that's going on, headed up by Laura Ingra and Georgiopoulos as well. They have resources. I suspect that they might be willing to share those as well.
Thanks, and let's ask a second one while you're here. This is regarding resources. For people with CF who are appropriate for palliative care, hospice benefits will often not pay for modulators, though these are medications that can be palliative in themselves. Have you encountered this, or I think also antibiotics sometimes can be palliative? Do you have any thoughts about this treatment?
Yeah, so we published a study, actually, just to reiterate this notion, we published a study last year in what journal is that? I can't remember off the top of my head, but I will tweet that just so folks can find it. Basically, it was a randomized study looking at hospice decision makers and looking at the factors that are associated with individuals being accepted to or declined from hospice care. And we saw some of those issues as well, particularly with antibiotics being a barrier to hospice care. Though in the free text comments, what we saw from some participants who were involved in the study, mentioning things like reaching out and liaising with your hospice services, they might not fully understand the role of these therapies. Again, they might not have a lot of appreciation for CF and CF therapeutics, so really starting that conversation was something that we saw in those comments as well. So yeah, I would say reach out and work with your hospice colleagues to see if there are workarounds.
Thank you. And I'll ask Dr. Ramos to come up. What is the effect of ETI on presumably normal CFTR in the donor lung, since there was some considerable number of patients in the consortium study that the driving factor was retransplantation?
Great question. So the ETI is not going to have an effect on the normal CFTR protein in the donor's lung that we know of, unless maybe this, yes, it shouldn't have an effect. There are some nuances to that discussion. Does it cause over secretion or hyper secretion? Maybe, but it shouldn't have an effect. The reason it was used for people with chronic rejection for whom retransplant was considered was to optimize all of their non-pulmonary manifestations of CF, including if they have malnutrition, maybe they have really bad sinus disease, which it can drip down into the lungs and cause more inflammation, more infections. And there are data showing that ETI has decreased dramatically the rates of exacerbations for people with CF. But also the number of antibiotic courses for sinus disease is decreased. And so when we saw that there were fewer antibiotic courses in our study, I think that may have been a real signal there and not just a COVID-19 effect. And so it's more the non-pulmonary manifestations that were being targeted by starting ETI in people who were considering retransplant.
Thanks, Kathy. And then a follow-up question. Can you describe the process or the basis for the recommendation of FEV1 of 25% in the guidelines?
Yeah, it's a little controversial, I know. There's no data, and we need to give some guidance to the lung transplant programs. And so 25% was chosen, but it's not based on strong evidence. We need more information, and now. There are 2 years of CFF registry data since Trikafta became available, so maybe this data will become available, but this was a consensus recommendation, not based on a specific paper or finding.
Thank you. I have a couple questions for Dr. Koff again. What is the expected duration of efficacy for phage therapy?
Oh, great question. I actually want to just go back to the safety question. I thought it just occurred to me to kind of mention some of the things you can read in the Russian literature. In particular was an example of folks go into a town and giving phage therapy to 30,000 individuals that were living there to prevent dysentery. So that included children, mothers, breastfeeding, elderly, et cetera, all age groups, all ranges. And they basically, again, some of the follow-up information is lacking, but basically went in and came back 6 months later and asked them how they were doing. And so we don't have a tremendous amount of information, but there's a huge evidence of exposure to different age groups, which I wanted to highlight. In terms of the efficacy, I think that's a brilliant question and remains to be seen. I think it's going to depend on the bug that's being targeted, duration of treatment, and also some of the effects that we're seeing in terms of increasing the bacterial load and how long that occurs for. In the cases that we have been focusing on, and I think the clinical trials will also kind of using this range, we're seeing phage delivery in the range of 5 to 7 days, sometimes extending out to 10 days. And that we will have safety data and efficacy, potential efficacy data in the sense that we'll be seeing endpoints for the change in bacterial load and the potential impact on lung function. Although I think in Europe, Trikafta is probably going to be less of a significant time point. And so this is, I think, one of the aspects that is rigorously being studied, and we need more information from that. I think we can also expect that it's probably going to be different for different pathogens, right, in terms of how the host responds, and perhaps most importantly, how the microbiome could be impacted by a phage cocktail, single phage, or targeting specific binding, and seeing if there is evidence of other bacteria kind of coming into the community. For our cohort of these 9 patients, we did not see any evidence that when we decreased Pseudomonas bacterial load in the sputum, there was no evidence that there was a change in the microbiome such that MRSA or Burkholderia or some other significant CF pathogens entering into the niche and taking over. And so that's encouraging, but I think we need that from the rigorous clinical trials.
Thanks, John. One other question. Can you comment on the goal of eradication versus to what extent is this just part of our treatment strategy?
Yeah, that's a really important point. I think for individuals with established bronchiectasis, we should really be considering this as a therapeutic, and eradication or clearance of a bug, I think, is limited to expect. I think when the patients that go to transplant, there are bacteria in different nooks and crannies of the lung because of the structural changes. And so I see individuals with structural bronchiectasis as really this is part of the treatment algorithm in combination with antibiotics, anti-inflammatories, all the other things that we're considering. I think as we, with ETI and other modulators and other therapies, I think that we're seeing less and less bronchiectasis. The potential for an eradication approach is there because the phages are incredibly efficient at killing bacteria, and and allowing for the host immune system to remove it. I think those are different types of studies that need to be considered, and probably at younger age groups, or as we see patients on modulators coming into adulthood who do not have Pseudomonas, the potential for us to do some type of parallel study for eradication with older patients is really, I think, an interesting idea as we have emerging safety data and others. And so I think those are the 2 ways that we could consider this, but I'm open to a discussion about that.
Thank you. I'll ask Dr. Cavalier-Rados. So we have a question here. How do you see ETI impacting the use and need of palliative care in CF? Would it increase needs because people are living longer with chronic symptoms, or do you see a decreased need?
That's a great question, one that we get often. So I believe that there is still a continued role for palliative care in the area of ETI. We still know that people are going to have symptoms, might have different symptoms coming up, might also be adjusting to a new normal, for example. We, like I mentioned, we have one clinical trial specialist palliative care right now. What we're seeing in the trial perhaps right now is that, again, lots of conversations about how do I reconcile a new identity, how do I sort of think about having conversations with my families and my clinicians about new goals of care, for example. So I believe that there absolutely is a role for palliative care, though that role may be changing over time, and we're studying right now.
Thank you.
Did you see another?
There was a question for Dr. Ramos. And the question was, were you monitoring sweat chloride in post-transplant patients taking ETI?
Thank you for the question. So in the study that I presented, it was just an electronic medical record study where we collected data before and after they started Trikafta or started ETI. Right now, we just got funding, thank you CFF, for doing a pharmacokinetic study in people who are either newly initiating ETI or have been established on ETI post-lung transplant. And we'll do the pharmacokinetics in an intensive PK day and check a sweat chloride test on that intensive PK day. And we'll get their baseline sweat chloride from the registry, just like they do in CheckSC. And so that is part of our plan. And in the next year or so, we should have those data.
And Kathy, can you just speculate on what role did COVID and COVID precautions take in decreasing transplant referrals over the last year or two?
Yeah, I wish I had mentioned that on the slide when I showed it. I glanced over the part where the other graph on the slide was lung transplant for all diagnoses, and there was a tiny dip in all lung transplants in the year 2020, but it is back up on trend for all other diagnoses. So the effect is really just ETI in CF, and the non-CF transplants are on trend for how they were pre-2020. So Dr. Perry asked whether or not the COVID-19 patients were sort of taking the lungs from CF patients, since some COVID patients are getting transplanted. The number of COVID transplants is pretty low, and I think that it was seen as super experimental in 2020, and I think that there are maybe more now that have lived longer post-COVID and be getting transplanted, but the numbers are pretty small, and it's more likely that COPD and IPF patients are absorbing those extra available lungs.
Thank you.
Although there aren't many extra available lungs.
I have a question for Megan, Dr. McGarry. So with regards to what you presented with the IRT and not having a cutoff point, but instead having something that changes over time, how do you see sort of the model program, I guess, for newborn screening, and how could you see things changing in the future?
Yeah, so I guess the question is, do you do fixed versus floating IRTs? So the floating IRTs with every batch run, they are just, the top percentage are going to be positive, versus the strict cutoff, it will vary every single batch about how many percent are actually going to be positive. And what's nice with the floating is that it takes into account all the other variables, because IRT is, it needs to be handled very carefully. So it allows for changes with that. And that especially with climate change and heat, your population over time, your RT may change, and so then you're not actually getting the percentage that you want. So if you're going to do a fixed, you would need to reevaluate, twice a year, looking and changing it. It makes it so that you're much more likely to have missed cases if you're not monitoring them carefully. And so when they compare back and forth, the floating IRT really does decrease your missed cases. So I think there are a lot of nuances to the newborn screening programs, and there needs to be a lot more discussions and comparing programs to see what really is the ideal program.
Thank you.
We also have a microphone over here. If anybody has questions that you didn't want to figure out how to.
I think we had another transplant, Kathy. So then, with regards to lung transplant and equity, how does adherence and social support impact transplant candidacy, waitlisting, and comparing this to high socioeconomic and low socioeconomic groups?
That's a great question. And when we did a study with Dr. Stevenson and the Canadian group and looked at outcomes for people with advanced CF lung disease in Canada compared to those in the United States with advanced lung disease, what we found is that the Canadians were more likely to have their advanced patients make it to transplant, less likely to have their patients die without transplant than those people who live in the US. But the effect was so mostly driven by the patients who are on Medicaid insurance. And so low socioeconomic status is definitely a barrier to getting to transplant. And how much of that is implicit bias of providers thinking they won't be able to do it, they won't have enough support, they won't have enough money, versus it's really a bad idea to transplant this person because they're going to be worsened by transplant. They're going to, die quickly after transplant. So it is a delicate balance of trying to advocate for people in whom implicit bias is preventing them from being referred or considered. I think that we should be referring people even if we think they're probably not a good candidate for transplant, because going and seeing the transplant program, there's a carrot and a stick, and the stick is you're not going to be eligible for transplant if you don't modify your adherence behaviors, as an example. And so I think sending people to the transplant program can be really helpful, even if you think personally that they might not be a good candidate. You have to communicate to the transplant program what your concerns are so that everyone can work together to try to modify any barriers that are modifiable. And so we know that Hispanic patients are 3 times more likely to die without transplant than non-Hispanic CF patients. People on Medicaid insurance are twice as likely to die without transplant than people not on Medicaid. And so there are systemic problems here because it's not all factors that really would lead to worse outcomes. And I think that we need to educate our patients with CF to help them understand why we don't offer transplant in certain circumstances and help them change their circumstances if it's possible.
Go ahead.
Let me ask a follow-up question on this social providers. So one thing about being studied from Canada and the US is that even in Canada, close to the same number of patients were not prepared and died without being referred to transplant. Once you made it to the transplant program, you got on the list, being able to transplant. But they still had a high number of people without referral.
There were some people in Canada who were not referred for transplant and died without transplant, but their proportion who died without transplant was lower.
Once you were listed.
No, even before listing.
I remember looking at this different, it was like a high number of people that died without, being referred or something like that.
I don't think that we found that they were dying. I'm looking to Dr. Stevenson, and she's nodding with me. I think that the people in Canada
Well,
were.
referred to the court of list, basically, we got to know much more likely. So how much of this is the transplant program related
That the transplant program saying no?
Body of saying no, because there may be differences between bodies.
I think there are different socioeconomic barriers in Canada than in the US. There's universal health care in Canada, and medications are covered, and there are still geographic barriers because people live remotely in Canada and may not want to move to Toronto or Vancouver to a place where there is a transplant center. But I think that the geographic distribution in the US is much larger. The disparities between rich and poor are much larger in the United States. And so, yes, I think there are barriers to referral in Canada as well. But I think that people were less likely to die without referral in Canada as well. We just don't have referral data in the same detailed way in the Canadian data. But they definitely die less in Canada than they do in the United States.
Dr. Stevenson, any comment? Not to put you on the spot.
Thanks, Kenneth, for that comment. But I think that in Canada, for sure, there's socioeconomic barriers as well. And as you said, Kathy, we didn't have the referral date for a lot of the patients. So we had listing date and obviously transplant date. So we couldn't really look in detail about who's referred. There's definitely people who die without transplant, and a large proportion of patients in Canada that die without transplant as well. So we have to look at why those patients are dying and not necessarily getting referred. They may be referred, but may not be referred. And I think the socioeconomic barriers, although they may be less in Canada for certain reasons, there definitely are barriers in Canada as well.
And non-white patients in both countries had an increased risk of death without transplant.
Yes.
I think there's one more question actually for you. This is a question that I've come up with. So with regards to contraindications to transplant, one of the things that we run into a lot is reduced BMI, right? So can you comment on that and the associated risk in the CF population post-lung transplant?
Yes, there are data about this. And so we published a paper that was in CHEST in 2021 maybe, that looked at people who had a low BMI with CF, and we compared their post-transplant survival to COPD patients who are regularly transplanted. The COPD patients had normal BMI for the majority of the cases, and people with low BMI and CF live just as long as people with COPD who get transplanted. And so the title of the article is something along the lines of CF patients with low BMI have acceptable survival after lung transplant. And so certainly there are extreme cases of low BMI where the surgical risks are increased, but we used a threshold of less than 17 in that paper, and people with a BMI less than 17 do the same with CF, and less than 17 do the same with respect to survival after lung transplant as COPD patients, and maybe better than the IPF patients.
Thank you.
I think we'll have a couple more phage questions. I think there is some concern about exuberant inflammation following phage. Has that really been reported? Have you seen that? Is that a problem?
Yeah, that's a really interesting question. So the idea is that phage is going to kill a bacterial population. The bacteria are going to release toxins and products that are going to reduce inflammation. And I think we have not seen any examples of that. In terms of immediate response, there's been no toxicity associated with immunization in our hands, and we have seen no events for a clinical trial. And so then the question becomes, over time, can that occur? In our cohort of these 9 patients, the most common description was low-grade temperatures and feeling malaise, fatigue. And one patient described to us, and I think it always has resonated, it felt like they were being treated with antibiotics that were working. And so in these patients who had multi-drug resistant and drug resistant infections, they at day 2 or 3 started noticing these symptoms that were very consistent with what was the patients were describing to us as what it feels like when they're in inpatient treatment for an exacerbation. And so we have not seen any evidence of this type of lysis kind of syndrome. I have not participated in many cases of IV therapy for sepsis. I think that's a place that this has to be considered. I think if we're talking about that type of pathogen, I think that's something that is going to have to come up on our radar with more caution. But we have not seen evidence for this.
Thank you. There was another question that came up. Now I've lost it, but it was oh, here it is. How do you see us using phage therapy? Do you see it using with or without antibiotics? Do you see it being used with an alternating approach?
It's a great question. The study that I wanted to do initially was alternating phage approach so they could nebulize over 3 to 6 months so they could be incorporated into kind of our standard inhaled antibiotic regimen, potentially alternating with others. I think this is where the safety information is going to be really important, and I think there's clearly going to be a synergistic effect with antibiotics, and I think there's some still important studies that need to be done in terms of how the bacteria interact with both the antibiotics and the phage. But you can imagine that for an exacerbation, right? Inpatient and potentially or outpatient exacerbation, adding phage onto the antibiotics to see if we can make it more effective. Perhaps most importantly, if we can shorten the duration of the antibiotics that we're giving so that we can save those for the future, and phage can kind of be inserted in that way. But I think there is going to be a role for chronic therapy for chronic phage therapy from a nebulized approach to target individuals that cannot clear their Pseudomonas, their NTM, or other bacteria to help them stabilize the disease. And that's potentially in folks that have more established lung dysfunction in the era of modulator. And I'm not exactly sure what that'll look like as our younger individuals come into adulthood with better and better lung function. But I think there's going to be the potential to combine it. And use it in these different approaches. And I think those are the studies that we really need to pursue so that we have information and safety and efficacy data in those examples.
Okay.
Question follow-up for you. So are you worried that if a person goes on chronic therapy with phage, that the phage that they start with will no longer be successful as their pathogens adapt to the new environment?
Yeah, it's a great question. So we actually want that to happen from our strategy. So we're using phages that are going to drive the bacteria to change. And in a predictive way, we can actually push the bacteria to change in ways that are beneficial to the host. And I think the FEV1 benefit that we saw likely relates to the fact that we induced antibiotic sensitivity in the patients who were then being treated with antibiotics that were available to them that weren't available previously. But I think most importantly, if you target LPS receptor or you're targeting the type 4 pilus, which is involved in pyocytin production, which is an inflammatory mediator for that the bacteria produce, we're seeing decreased inflammation when we look at the bacteria after the treatment. And so what I mean by that is if we put those bacteria into a mouse model or or look at their products on epithelial cells, we see decreased inflammation. And I think this type of strategy could be a really exciting long-term strategy, kind of that old Mike Tyson video, body blow, where you're just hitting the bacteria at different levels, but without the ability to eradicate because there is structural bronchiectasis, and the patient will do much better long-term from that approach. So I think that's one strategy that can be pursued. The negative, obviously, from a regulatory side is there's probably a large library, that needs to be put together. But the same thing is going to be required for a cocktail, right? You're going to have the same problem if you give a cocktail to all the patients over time because the Pseudomonas in particular is just fantastic at becoming resistant to the phages that you're deploying. And so I think these actual strategies are going to convene into some similar approach. And I would guess that maybe we're going to use cocktails for our inpatient severe exacerbation or severe outpatient exacerbation that requires antibiotics, but maybe move toward a single sequential phase strategy to continue to push the bacteria to be less of a problem, and maybe we'll get closer to actually clearing different communities of bacteria long-term and have that type of victory. And then the overall approach is to use this to decrease the amount of antibiotics we have to deliver to our patients, which are toxic, and we're just not developing fast enough for the bacteria that are occurring. And we don't want to, we don't want to be stuck with limitations for our patients when we're consistently using bacteria to treat, antibiotics to treat their exacerbation. So it's a great question, and we're trying to flip this strategy into something that can be practically used to our advantage. And I think it's going to work for Pseudomonas. That's very different than non-tuberculous mycobacteria. Like you saw from those cases, the bacteria are not becoming resistant to the phage, right? We just need more phages like that so we can treat a broader population of patients. So there are going to be some differences, and I hazard to guess that it's probably going to, in gram-negatives, we're going to need this type of a trade-off approach. But mycobacteria, and even MRSA, does not require this level of trade-off quite as rigorously. That's a great question.
Great. Well, I think that's about everything for today. So I want to thank to all our speakers and all of you for attending. Enjoy the rest of the conference.